Hello everyone, welcome to the Physiotherapy Junoon channel, and this is the Pathological Gait series part 3, and I, Dr. Vinita, MPT Ortho. We will discuss first in this the leg length discrepancy. In this, the two type we seen, one is anatomical, one is functional. In anatomical, leg length discrepancy occur when the legs are actually in different length anatomically, as measured with a tape measure or accurately by the long leg x-rays. Four gait abnormalities in this included, like the circumduction, hip hiking, stippies, or vaulting, are closely related in that they are designed to overcome the same problem as functional discrepancy in leg length. Before we see the conditions, we see that what is the functional discrepancy. Leg length discrepancy means that the legs are not necessarily different lengths, although they may be, but that one or both are unable to adjust to the appropriate length for a particular phase of the gait cycle, like in swing and stance phase. Why this gait pathology? This is usually occur as the result of neurological problem, like in the spasticity of any of the extension or weakness of any of the flexures tend to make a leg too long in the swing phase, as does the mechanical locking of a joint in extension. When your leg is moving, when your leg is in swing phase, the extensors, if extensors are weaker, uh, extensor are in spastic phase, or the flexors are weaker, then you see that the leg length discrepancy. Conversely, the spasticity of the flexors and the weakness of the extensors or a flexion contracture in a joints make the limb too short for the stance phase. Other causes of functional leg length discrepancy include musculoskeletal problems such as sarcoiliac joint dysfunction, ASIS, PSIS. These conditions are due to the flexure and extensors weakness and the tightness, or you can say the spastic. An increase in functional leg length is a particularly common following a stroke, where a foot drop due to anterior tibial weakness or paralysis may be accompanied by an increase in tone in the hip and knee extensor muscles. Then we proceed to the next, how to overcome this pathology. The gait modifications designed to overcome the problem may either lengthen the stance phase leg or shorten the swing phase leg, thus allowing a normal swing to occur. They are not mutually exclusive, and a subject may use them in combination. The gait modification employed by a particular person may have been forced on them by underlying pathology, or it may have been a matter of chance. Two people with apparently identical clinical conditions, same conditions or identical conditions, having found different solution to the problem, because everybody have a different gait and a different conditions and a different environment, so there is everybody, every person have a different solution for the problem. Then we proceed to the circumduction or a circumductory gait. Ground contact by the swinging leg can be avoided if it swung outward in a movement known as circumduction. Outward movement or a circular movement, the swing phase of other leg will usually be normal. The movement of circumduction is best seen from in front or behind. Circumduction may also be used to advance the swinging leg in the presence of a hip flexors. weak hip flexors by improving the ability of the adductor muscles to act as hip flexor while the hip joint is extended. The hip flexor weakness, the hip adductor muscles, they act like flexors so that this gait is happened. In circumductory gait, in fixed abduction deformity or in hemiparesis, not hemiplegic, it in hemiparesis, the PT moves his limbs, patiently moves his limbs while dragging his body along with the limb in a semicircle. You see in the picture, or you see the steps, the circumductory gait. Next is the hip hiking gait. In the hip hiking is a gait modification in which the pelvis is lifted on the side of the swinging leg by contraction of the spinal muscles and the lateral abdominal wall. The movement is best seen from behind or in front by contraction of spinal muscles and the lateral abdominal wall. The movement is best seen from behind or in front by tipping the pelvis on the side of the swinging leg. Hip hiking involves a reversal of the second determinant of gait, pelvic obliquity, about an anterior-posterior axis. It may also involve an exaggeration of the first determinant, like in pelvic rotation about a vertical axis, to assist with leg advancement. The hip hiking gait modification is by, according to the manual by New York University in 1986, hip hiking is commonly used in slow walking with weak hamstrings. And since the knee tend to extend prematurely and thus to make the leg too long towards the end of the swing phase. It is seldom employed by limb lengthening due to plantar flexion of the ankle. According to the hip hiking gait, we see that excessive elevation of pelvis on swinging side. Impairment, what are impairment? Inability to functionally shorten or swing leg, possibly due to a weak hip flexor muscles. Next is the steepest gait. In this gait is very simple swing phase modification consisting of exaggerated knee and the hip flexion. Here we see that in all the gait in leg length discrepancy, we see that the knee extension or the hip flexors weakness or spasticity. You may vary with the very minute things, and with the hamstring or with the gluteus and with the calf muscles. So you have to concentrate on the patient during your evaluation part, that what are the weakness and what are the spastic part of the body. If flexors are weakness, if extensors are weakness, which muscles are weakened. So in the step is very simple swing phase modification consisting of exaggerated knee and hip flexion to lift the foot higher than usually for increase the ground reaction forces. Let's see, it is particularly used to compensate for a plantar flex ankle, commonly known as foot drop, due to inadequate dorsiflexion control because patient foot in plantar flexion. So patient can't dorsiflex, or he she having no control on the dorsiflexion part, which will be described like in the vaulting or other gaits. Increase hip and knee flexion, improve ground clearance for the swing phase leg, in this case necessitated by foot drop. Here you see that in normal cases you see that the plantar flexion during the swing phase, and in the steepest gait you see that patient can't dorsiflex the foot, inability to lift the toe of the ground. But in normal gait, patient easily lift off the foot from the ground and easily dorsiflex the foot. Thanks for watching my video. Please like, share and comment, and let me know if any doubt or any improvement in my videos. Thank you so much.